The big, huge, radical thing that they started was the use of puberty blockers in children who did not have precocious puberty.
Mhm.
We were seeing teens who were asking for things like neo pronouns. They wanted us to call them it. I said, "We are harming patients." And their response was, "I know, but what do you want me to do about it?"
Jamie, thanks so much for joining me today. I really appreciate it. For our viewers, could you give a little bit of an introduction as to who you are, your background, and how you found yourself being a whistleblower at the clinic that you worked at?
Yeah, absolutely. So, my name is Jamie Reed. I am a clinical research coordinator by training with a master's of science. And I was working as a case manager in a pediatric transgender center here in the States in Missouri. I was there for a little over 4 years. And what I found in that time was just increasing ethical concerns about the patients that were being medicalized, is the term that we used often. So they were being put on really serious treatments like puberty blockers and cross-sex hormones after really limited amounts of therapeutic engagement. So I found myself in a position where all of the internal conversations I was trying to have with the providers and the team around me seemed to not be going very far. And so I ended up leaving the center and becoming a whistleblower about 3 months after leaving.
And also, I think one thing that's really important to put across at this point is that you're married to a transgender man and you've also had gender confusion when you were younger as well. So if someone was to accuse you of being transphobic, it's hard when actually those facts are in favor.
Yeah, I don't see myself as anti-trans or transphobic at all. I see myself more really wanting individuals who struggle with gender issues to be treated with the best science, the most robust guidelines, and have really serious, careful consideration, especially when we're talking about children.
Mm. I think it's such a good time to be talking about this because it seems like it's happening really fast and no one has had any time to process this and to really actually look at how do we care for these individuals in the best way possible.
Yeah, it did kind of, in some ways, come out of nowhere. It came out of the Netherlands, so we know what country the idea came from. But once it hit the United States, it just exploded in this very, really tough time frames. We had all these young people who were being affected by COVID. In our country, we had a lot of lockdowns. So a lot of adolescents and young people were not even able to go to school and have those social functions. And we found all of these teens then completely absorbed online. And
Mm.
so there was just all of these confluences to see this explosion of these kids with these identifications and then with these centers popping up.
Tell me more about this coming from the Netherlands. What happened to actually bring us to where we are today with
Yeah.
people?
The Netherlands for a long time were treating trans adults, and they were finding that for a lot of adults, even transitioning, they were still struggling. It's still a struggle for people who have gender issues. And they thought that maybe a way to help these adults was to start transitioning people younger and younger. So I
Mhm.
think the first kind of slippery slide that they went down was they started giving cross-sex hormones a little bit younger, so 18 to 16. So they kind of started sliding in that direction. The big, huge, radical thing that they started was the use of puberty blockers in children who did not have precocious puberty. So, puberty blockers were created to treat this tiny little group of kids who started puberty much, much earlier than they should be. I'm talking like 2, 3, 4 year olds starting puberty. So they had this idea to start giving younger adolescents puberty blockers to stop their body from developing the way that their body would have in an effort to make them pass better as trans adults.
It's really helpful to know where this came from in the first place. So then what happens for individuals when they receive puberty blockers? What happens in males and what happens in females?
So the idea behind it was that people would not develop the secondary sex characteristics that would be associated with their natal sex. So if they were boys, they would not develop an Adam's apple and would not develop the same body physique that we can kind of tell when people are born male that they are male. And for the girls, it would be to not develop, primarily, it would be to not develop breast tissue.
Mhm.
So, in essence, the idea was to stop the body from growing into the secondary sex characteristics. The downside that we find now is that it really does have a longer term impact on the brain to not go through puberty when your body is supposed to be going through puberty.
Mm.
And then we also see some really detrimental effects for the boys. So if a boy is having their puberty blocked, we're finding now for the most part that's going to impact their fertility for life and
Mm.
their sexual function for life. And so those are two things that kids really are just not able to consent. We really can't be asking 6, 7, 8 year olds to make a decision about their lifetime sexual function and fertility.
That's really, really concerning. So you have a young boy and he's given these puberty blockers and then won't be able to function sexually for life. And the damage that's been done here is completely irreversible. That if later in life
Yeah.
they change their mind. And then what about for females when you give them puberty blockers? What happens there?
So what's interesting is, at least in my clinical practice, most of the girls who are identifying as trans right now in the United States are coming to these centers way too old for puberty blockers. So I still see a huge element of social contagion in these girls where they are identifying as trans around 15, 16, 17. So
Mhm.
much they've already been through puberty. They've been having periods for a number of years. They've already developed breast tissue. So they're not getting the puberty blockers as much as they are getting testosterone.
Mhm.
And they're getting testosterone pretty much as soon as they come out and come to a clinic like this.
That's so concerning. I won't kind of go into I won't go into too much about like my work and stuff, but I work with identity. So I work with dissociative identity disorder. So I've got a really good understanding of actually how gender issues can play out in relation to it being an identity issue as a result of trauma rather than it actually being really gender issues
Yes.
that need to be
Yes.
treated in this way. So I don't want to kind of, I don't want to go into too much of my stuff, but I'd love to hear your opinions on that and what you've noticed where you've been like, that doesn't need to be treated as a gender issue. This needs to be treated and the person needs to be supported in a very different way.
You nailed it. And so many of the natal girls that we are seeing, these teen girls, were also developing some of these other social contagion identity related issues. So they were claiming that they had DID. They were seeing a lot of this online. They were also claiming often that they had tic disorders, and tic disorders are also rare in girls. They don't onset often at that age. They often start earlier and in boys. Just so many of these things that are just showing us that especially girls right now are really struggling in this culture with their identity and their formation of their identity in their teen years.
It's such a good point. And actually, something that I'd like to mention at this point is that every single client that I've ever seen with DID, and I've seen a lot of them because it's one of my area of specialty, they've never not had gender alters of a different gender. And my understanding of this is actually the alters are a protective mechanism. So not always a bad thing because they can step in when times get tough, when emotions are very distressing and the main identity just can't cope. Then often it's alter of a different gender that can step in. Sometimes it's alters of the same gender, but with every single individual I've ever seen with DID, there's always multiple genders. So I've seen firsthand that actually with trauma often comes identity issues and
Yeah.
a way that it helps them cope to be able to switch identities. And for someone to kind of just assume that, oh, this is someone who's like being born as the wrong gender and we need to transition this person, it's just very concerning to me.
And your mention of trauma, one of the things that I find in a lot of these patients too is that they do have trauma from a very early age. And also, a lot of them have histories with sexual abuse and sexual trauma. And one of the things that I was advocating for within the center was that the appropriate line of treatment is trauma-based therapy, is therapy to address the trauma history. In some of these patients, they had never seen a trauma therapist and never worked on the history of sexual abuse at all. And yet we were okay with physically transitioning their bodies.
I've worked with an individual who had autism, and because of their autism, they were really good learning all the information and getting all the facts and went hyper focus on it. And actually, it was a superpower, their hyper focus. And it's so impressive when someone can literally like list off all of these things. But they used the loopholes in the UK law to then transition at a very early age. And then actually, the parents really couldn't step in.
Yeah.
The individual was so powerful and was able to use all these loopholes, transitioned, and then actually it didn't fix any of the mental health problems. They wanted to detransition later on, end up getting sectioned because their mental health deteriorated. And this was actually quite a long time ago where I didn't really have that much information about this issue. So I'm just kind of curious about what you've seen and any cases you might want to refer to where you kind of saw things escalate really quickly and then goes too far and then the person actually deteriorates and they're not helped in a way.
Yeah, we actually saw a number of patients with very similar presentations. The autism correlation is huge. But towards the end, one of the things that was just so troubling to me was that we were telling families, put your child on this blocker or give your child these cross-sex hormones and they will get better. And instead, we were just getting so many contacts from parents 2, 3, 4 months later, where they were directly saying, my child is worse. Their mental health has deteriorated. We had patients who went from maybe having passing suicidal ideations to having suicidal attempts. We had patients, there's a mom in particular who I have had contact since I blew the whistle, and her child was put on a puberty blocker, and she contacted us a few months later and she said, my child is a shell of their former self and was now on close to 5 psychiatric medications. These are really hard treatments for anyone to undergo, which is part of why I think they should be limited to adults who have mental health supports in order to do this. But to completely change your body and your social presentation in the world as another gender actually requires a formidable sense of self and mental health stability. If
Yeah.
you don't have that stability, undergoing one of the hugest transformations we could ever see a person do is of course going to deteriorate someone more.
Yeah, I mean it's crazy that people don't have to work on their mental health first and then be like, look, let's work on everything to do with your mental health and then let's come back and see. There was another case, a family came to me and the daughter was wanting to be affirmed as a male, and I assessed the family and I could see the problems in the family. And it's a challenging thing as a psychologist because actually I was picking up on autism in the dad and he had never been diagnosed. The mom, she was really struggling in the relationship and there was really bad communication problems. And it was quite obvious to me that, like, of course, a teenager who's going through puberty, who, like, the mom definitely didn't feel kind of heard in the family, felt she didn't have a voice, and she was really struggling. So, you know, it was just really obvious to me, like, okay, this is, you know, this is a family that's struggling. The relationship between the mom and dad is tough. I can only imagine kind of what it's like for the teenagers. So it was really obvious to me, you know, these are identity issues. We need to just support this individual and do, you know, about a family intervention if they're open to it, and then also the individual therapy. And let's just, you know, it's absolutely fine for people to lean into whatever gender they want to. Like, we can completely support that, but let's not start giving someone hormones and transitioning them and, you know, making decisions or helping them make decisions that they can never go back on, because it just seems so obvious to me that a lot of support is needed. But I think that the understanding and the awareness and the kind of the guidance on this is just not, it's not there for psychologists. I think a lot of psychologists are seeing individuals like this and just, you know, just not having the information on what's best.
I'm so grateful that you brought up the family functioning, Because one of the conversations that is happening in your country right now and in mine is this idea about the school systems and education, and if we should even be notifying families when a child is coming to school and raising, a statement around their gender. And one of the things that's so important is, if you can imagine a family that's already struggling with functioning, where maybe you have a dad who is undiagnosed with something and a mom who's struggling, to then triangulate and add this element where an outside institution like a school drives an even farther wedge between the child and the parents. Instead of working to start healing the family unit, we just see how these issues get bigger and bigger. And I believe that I was helping some families get torn apart.
Mm,
We would have parents who disagreed about the child's gender presentation. And
yeah.
instead of seeking out family therapy to help the parents come to cope with a challenge in their child together, we were encouraging parents who wanted to put their kids on medicine to divorce their spouse.
Mm,
And
wow.
as a children's hospital, we should have been grounded in the principle that a family unit that can be held together and strengthened is overall better for the child. And even in the cases where divorce is the best scenario, you still want a functional family unit where those two parents can then successfully co-parent later. And this ideology, this idea, these concepts are really tearing apart the whole fabric of keeping families together too. And
Yeah.
that's just not good for anybody. It's not good for our whole society to have single parent households.
That's so well said, Jamie. If I was an individual, let's just say a teenager, and my parents, let's just imagine, are just not understanding me emotionally, I'm going to have some kind of identity issues. I'm not going to really know my place in the world. I'm not really going to have a lot of confidence. And I'm going to play around with my identity to be validated. So I might, do anything. I might dress very differently. I might develop an eating disorder, but I'm going to do something to try to figure out who I am and how am I going to get validated. And it's a really interesting point you made, because then if someone just supports my parents and is like, look, she's just a teenage girl, she's having a difficult puberty, her self-esteem is not in a great place, just stick together, just be kind to her, just support her, tell her she is good enough, just give them a bit of like parent, guidance. And then actually there's less conflict between the mom and dad. And then they're like, okay, we just need to stick together. We just need to tell her she's doing, a good job at being a daughter.
Right.
And then you have a family where, okay, the parents might not be emotionally very mature, and yes, their relationship might be, quite codependent, not very good, but actually you're just supporting the parents to be able to manage the situation, rather than being like, absolutely, she's a boy, send
Yeah.
her to have these life-changing medical interventions, she's going to be happier, she's not going to be suicidal, and then it's just chaos. Of course that family those parents are probably going to divorce, and God knows what kind of relationship that individual is going to have with her parents later, if she later sees that actually she wasn't protected with her mental health struggles that were all to do with the family stuff.
Yeah.
So, but I guess, yeah, it's hard for people to understand this because it's not the information that's been shared right now, or
No,
things are
it's not.
starting to change.
And it's not empowering to parents either. It doesn't empower parents to also be able to put the brakes on things. I think parents should be empowered, especially right now, to have actually more parental interventions, more, I'm going to use the word control in their own household. I
Yeah,
think some of the things that teens are experiencing right now is this total deluge of, I can be on the internet, I can access anything I want on my phone at any time. I was counseling parents sometimes just to be able to put back in place things like, you should be able to tell your child that they shouldn't have their cell phone in their bedroom and be on their cell phone at 2 a.m. on a school night.
yeah.
Things that you would think are common sense parenting interventions, we were seeing parents so disempowered, and so much of that unfortunately was because of things like the phones and the social media and all of these huge things that have changed these teens' lives.
The fact that you're saying, like, we need strong parenting, we need parents that know how to take control is really reassuring, because actually it reminds me of a parenting expert that I work closely with from time to time, and he basically gives advice to parents like, give your child two options so they feel they have some control, but the options need to be kind of limited. Like, do you want to come to the dinner table now, or do you want to come in 10 minutes? Essentially you just
Yeah.
want to get your child to the dinner
Yes.
table. And rather than being like, come to the dinner table now, you're giving them some choice and they feel like they have control, but also you're guiding them and you're understanding that they're too young to be able to make decisions for themselves. They need the comfort of knowing that the parent is actually in charge and is able to make these difficult decisions.
Absolutely.
So I want to kind of go back to, first of all, what was the year that you worked in the transgender clinic?
The clinic here opened in 2017. I joined the team in 2018, and I left just about a year ago, 2022. So about October 2022 is when I had left.
Okay, so you join the clinic and you join, everything's, you're kind of feeling enthusiastic and you want to support these young people. Why do you think there were so many people at that clinic thinking that the right thing to do was to affirm these people, give them puberty blockers, and help them transition so early?
There's a couple elements to that. So one element to that is what the clinicians had access to. And I think sometimes the good metaphor to this is, for every doctor who provides surgery, they see everything needing a surgical fix. So if you are a hammer, you see a nail, and that's kind of how you carry out your practice. So in our center, we had access to and clinicians who could prescribe hormones. These were pediatric endocrinologists. That's their job, is they prescribe hormones. We had very limited access to psychiatry and psychology. We had very limited access to high-level mental health providers. So there's a real challenge for people in the United States to access these. And then the way our insurance system works, every single time you take your kid to a therapist, you pay a copay. And for some parents, that's an expensive proposition for a weekly therapeutic session. So the endocrinologist would see the patient one time in clinic. It was a 1-hour visit. As long as they had a letter from a therapist, and sometimes that therapist only met the child 1 or 2 times, the easiest thing to do is to prescribe what the children are asking for.
Yeah.
And they are asking for these treatments. What's harder to do as a doctor is to say, no, I don't think this is the best thing for you. And that's a hard thing for a doctor to do when they have the treatment right there in front of them and could just go along with it. I read a book recently about the original Dutch and the original Dutch studies, and they were turning down about 30%, I believe, of the patients coming to them and saying, you're not a candidate for this. And we simply were never doing that. We were saying no. If the parents said yes, if the child said yes, and if they at least saw a therapist one time, we said yes too. That's not how medicine is supposed to work. There's supposed to be differential diagnoses, and statistically, there has to be some people that don't meet the diagnostic criteria. And just on a basic scientific level, that was another thing that was just making me go, this does not line up. Everybody cannot meet the exact same diagnostic criteria.
Yeah, I can relate to this in a few different ways. One is psychiatry, and I work with some fantastic psychiatrists who often prescribe medication that the individual really needs, but because it's their only tool, most of them are not trained in talking therapy. I've seen a lot of people where they've been put on, for example, antidepressants far too quickly, and talking therapy actually could have been empowering and could have kept them off antidepressants. And the other thing is the ADHD crisis. So actually, a lot of people were underdiagnosed. So there's more and more people coming forward who genuinely do have ADHD. However, often where people are looking for an ADHD assessment, there's just far too many people being diagnosed because they're asking for an ADHD assessment. Then the likelihood that they will get it, whether they have ADHD or not, it's just, there's something, not right there. So it sounds like the same kind of thing was happening in this clinic. Someone suspecting that they might truly be transgender, and then just straight away it's getting signed off, and then they just go through the process.
Absolutely. I think we have a culture where a pill fix is the easiest fix, and some of the harder work, the more holistic work, takes a lot of time and a lot of effort. You're
Yeah.
absolutely right with depression. Sometimes, yes, there are absolutely individuals who need depression medications. It works best when it's coupled with therapy, but there are also individuals who need support to physically go out and exercise for 30 minutes every day, and to sleep and to eat and have good nutrition and to take care of their body as a whole, and to go out in the sunlight, things that we know can help with some of those basic depression symptoms. Those things are often not supported to be tried first.
So you're working in the clinic, and then you start to notice, oh wait, everyone who's going through, it's like there's no no's. Even though, did you at this point make the link that actually it was 30% no's in the Dutch?
No, I did not even see those statistics until much later about the original Dutch clinic, but they were screening people out left and right.
What was the first thing that you noticed where you started to feel uncomfortable, and there was just something kind of intuitively saying, wait, there might be a problem here?
A lot of it came down to individual cases and guidelines. So we would have patients who simply did not meet the guidelines. And the thing about this field, so the thing about transgender healthcare, it's not a tightly organized field of medicine. So, in some other medicine, if somebody is going to be diagnosed with having diabetes, you do a blood test and you have a range in your lab values where you're pre diabetic or you are not. And we've decided that there is a clinical agreed upon threshold that once you meet this diagnostic category, you are now diabetic and you would benefit from a medication. We do not have that in gender care.
Mm.
So most of these guidelines are put out by an organization called WPATH. They have been changing these guidelines years and years and years of changes. And all of the changes has just made them looser and easier and looser and easier to just get prescribed. But some of these guidelines were so loose. For a young person, most of the general public thinks these people have been feeling like they have had gender distress for years and years since they were children. The guidelines said 6 months. So
Wow.
you could have a teenager who claimed something 6 months ago, and that would have been enough to meet diagnostic criteria. And then what would be even more interesting is the guidelines would say things like that should be documented. That 6 months, the best medicine, the best course of treatment would be that 6 month time frame would have been documented because they went and saw a therapist. And instead, we let the children do their own decisions. So if the child said, "Oh, I've been feeling like this since last Christmas," even though we had no way to verify it at all, we would go along with what the child said. Those are not strict diagnostic criteria. And then the other things were simple things like the patients were stating they had sexual history and never been acknowledged or had no trauma therapy. Um, Patients saying that their identities were still shifting and that they were going back and forth and they felt like they were this gender one day and another gender the next. Those were not strong. That's not meeting the guidelines in a strong way to warrant a treatment that will irreversibly change the child's body for life.
So then you started speaking to parents, and the parents were saying, my child has gotten worse. Their mental health has deteriorated since they started treatment. Could you tell me a little bit more about that?
Oftentimes, it was the parents reaching out to the center and primarily through the phones with the nurse. And so we were getting some of these direct phone calls. My child's getting worse. The other thing that we were doing in the center was we were collecting some mental health screeners. So for mental health providers, we use two screeners here in the United States, a PHQ-9 and a GAD-7.
Yep, we use them.
So yeah, anxiety depression screeners.
They're quite basic. So like
They're
and
so basic. Right,
on
right.
And if you give that to me, I like to be really positive. So even when I've been feeling low, like yesterday, if you give me the PHQ-9, which is a depression scale, I'm going to say I'm fantastic, not because I want to lie, but I like to perform well on tests, and it's so subconscious. And then we've got the other one that, people often, they want to, it's very obvious if you want to be signed off as depressed, like let's just say you want to be signed off work or whatever, just tick all the bad answers on it. It's like, it's very easy.
So we were giving this to every patient at every visit. And so most of our patients were, I believe, answering the way that maybe you're correct, that they saw that might get them the path that they wanted. But for some of them, this was I think that they were answering these in a pretty honest way. And we were giving these screeners from the very first visit, so way before they were ever put on a puberty blocker or cross-sex hormones, and then every visit subsequently. What I was starting to see in the data is that if the model holds true that giving someone these treatments makes them better, their scores should consistently, or for the most part, these patients' scores should be getting better. And they weren't. A significant number of their scores were consistently getting worse or just holding similar. But this would be where I would have data from the initial visit, the visit directly after getting started, 3 months later, 6 months later, 9 months later. And it just was not holding that the model itself was that they were getting better. And then you could also look at things like, were they having fewer trips to the emergency room for suicidal ideations? Or are they on fewer psychotropic medications? Or are they having less hospitalizations? And all of those things. And I'm not saying this about every single patient that we saw. You can see that there are some small group of patients who are getting better. But in order to overall give these really serious treatments to so many kids, you would want to see the majority of the kids who are getting these treatments getting better. And that just was not holding true.
It was a minority. So like the odd few here and there would get better, but the majority were all getting worse.
I would say that it was a third, a third, a third, which is an interesting thing because that, as a hypothesis across the board, I believe it's called a null hypothesis then, that if you have a third don't have any changes at all, but we gave them this irreversible treatment, maybe a third got better in the short term and maybe a third got worse. Overall, the treatment is not effective. You should see statistically, you would want to see greater than 50% in the 60-70% range of getting better if you felt like a treatment was effective.
Because a third where there was no difference at all, I'm assuming they were pretty bad, experiencing a lot of distress beforehand, and then continue to be pretty bad, experiencing a lot of distress.
Yet now we've also irreversibly changed their body for life.
Yeah. Wow. So then what did you start to do?
So a couple things. We had conversations as a team over and over and over again. This was considered a multidisciplinary team. So we would case conference the patients out. I was not the only one that had concerns. And we started tracking data. So one of the things in medicine is you can't just have a theory, you have to have data to support it. So we started putting together data sets of patients who were detransitioning, who were desisting. We were also looking at patients who we believed had significant concerns, which I think if anybody's followed me has now been widely known as the red flag list. So we had created a list of patients who we believed had red flags. And we also were compiling data sets of all of our patients. It had not been done when I started, so there was no tracking of patients from 2017 on. So I started to at least put together a data set of all of our patients. And it was in the data set of all of our patients too that I found that we were losing about 30%. So we had a loss to care rate of roughly 30%. And we were seeing detransitioners.
When you say you were losing that percentage, they were dropping out of treatment and you wouldn't see them again?
Yes.
So you didn't know what happened to these individuals?
No, we didn't know. But also the medical health record that we used is called EPIC, and it tracks patients across a number of different hospital settings. So even if we felt like they were lost to care to us, I could check in and see, did they go somewhere else? So this was not simply we lost them and maybe they're still getting trans care from this different place. Epic has a lot of features where you can see, did they transfer their care somewhere else, or they would tell us if they transferred care. So a lot of these patients would fall within a category of they were truly stopping or lost or losing or no longer engaging in this kind of care.
So would that mean that they've started medication, they started puberty blockers, and then all of a sudden they stop attending, so then no one really knows what medication they're
Correct.
taking and not taking? Wow.
Correct.
I'm curious about the habits, a bit like the trends and habits of where you worked. What was the language that was supposed to be used and not used? And like what happened there? And did you, how did that impact you in terms of
Yes.
being able to speak freely without being so self-conscious that you were saying the wrong thing?
Oh, wow. This is a great question. So language was highly policed, and I will admit that I was part of that police force. So one of the things that we actually did is myself and one of my coworkers, we would go across the hospital and go into different divisions and train people around what you should and shouldn't say. So we were telling people about language. Language started to shift, and I would say it also is bizarre a good word? So for trans individuals who believe that they feel like they have gender distress and would feel better in the world presenting as the opposite sex, for the longest time, they would ask us to use pronouns like just the opposite. So if a girl would say, I want he, him, his, or a boy would want she, her, hers.
Mhm.
We were seeing teens who were asking for things like neo pronouns. They wanted us to call them it, things that feel really degrading and really like you are becoming more and more complicit in these young people's mental health instead of helping ground them in a better place. And so there were conversations about the use of neo pronouns or referring to a number of patients wanted they, them pronouns. There's so much in this world about language where even today I'll say natal sex or I'll say girl or boy. You were not allowed to say that. You had to say somebody was assigned female at birth or assigned male at birth. To say otherwise would be seen as transphobic. To recognize the reality of biological sex would be seen as transphobic. And
That's a fact.
one of the things that I feel so much better about now that I'm no longer in that environment is one of the things that takes away is all of our ability to have the right to freedom of speech.
Yeah.
And so I no longer believe that it is my place in the world to put words or to tell someone else what words are allowed to come out of your mouth. If you are going to say things that you see fit, that is absolutely your right to do so. And I do not believe that it should be anyone's right to take that away.
It's really interesting, the pronoun thing, because when I started working with non-binary clients, they had to train me on how to use the they pronoun, and I wasn't very good at it initially, but they were so respectful and they knew it wasn't my fault. I just kept slipping up because I wasn't used to talking in that way. And then after a while I just got better at it, and then
Yeah.
I could say they because it was what they wanted, and I could easily respect that because it's one extra pronoun. And and that's fine. We have non-binary people on our team and we use they with those individuals as well. What I won't be doing is going beyond that. There's no extra pronouns I'm going to be using because
Absolutely.
just like ridiculous and it's confusing, and then you get so self-conscious about making a mistake. And I would never want to misgender someone because it's respectful to them to, in my opinion, just to try to accommodate. But when it goes into this crazy, like there's just so many pronouns that could be used, it's almost like, come on, it's just too challenging for anyone to adapt in that way.
It's so individual. It's trying to basically say that we have no collective society and we have no collective ability to work together or live together because everybody has to basically walk on eggshells. And, we're going to reach a point where everybody's going to be wearing a bloody name tag that has like these 8,000 different pronouns, that it doesn't work for a collective society. And it also just doesn't work in a medical field. I mean, we were training emergency room physicians, and we were having kids come in trying to say that they had these pronouns like rock or it or mushroom. And these doctors, on some level, they were right. They're like, this is asinine. We have patients coming in car crashes, and I'm having my time taken up by a 15-year-old who wants us to call them mushroom, and then getting mad and in distress when the rest of the world doesn't know that their pronoun is mushroom. Like, come on. Like, we
Yeah.
have to be able to still function.
There's trends that happen. Like when I was young, there was the emo trend, there was the goth trend. And if you didn't want to be any of those, you could pick something else that was just a bit like outrageous. And also you see that like a teenager sees that they can take control over situations by like picking
Oh,
something like that, particularly if they know it's going to be a bit difficult. And they might feel very proud of it because it's them like trying on different clothes in relation to their personality. But you have to draw the line, or you have to kind of have boundaries,
yes.
for example, I went through a period when I was about 15. I was just wearing all purple. Like everything was purple. Like all my clothes, my hair was purple. I got like purple lipstick and I had like purple mascara. And I just had this phase of just wanting to like play around with my identity. And like I wanted people to react to it. If I then had options of pronouns to go with the fact that I was purple, like, it's just really taking the piss out of all my teachers, my parents, and like
Yes.
making them do something when actually I was just trying to be an individual. I didn't want to be an emo because it didn't quite fit. I didn't want to be goth because that didn't quite fit. So I decided I was purple for a while, lasted for a year or two, but I didn't force people. People would just look at me in the street like she looks a bit weird. And a few of my friends kind of jumped on the bandwagon, but no, I wasn't forcing anyone to refer to me as anything different. So I think it's just, there has to be some kind of boundaries. Otherwise, people
Absolutely.
really play around with seeing how much they can manipulate other people.
Yeah. I don't know. Have you ever spoken to Dr. Oz Hakim in
No.
England? He's a genius in this field, but he definitely sees and draws some of those parallels to the goth movement, the emo kids. And one of the things he has talked about is how those were grounded in, yes, they were grounded in subculture, but they were grounded in music. They were grounded in clothes. They're grounded in experiencing the world and exploring those things. And I wish on some level that we could see kids going back to those things.
So liberating and
Yeah,
refreshing, because you could be an emo for like 3 years and you could like act quite emotional because that's what you're feeling, and you can get the validation of, oh, she's an emo, like she really fits into those groups. You can make new friends because like they're emos too. And then you have a 3-year span and then you just grow out of it, and then you start to be like, okay, not feeling as emo-ish anymore. And then
yes.
it's gone, you look different, and like it's no one even remembers that you used to be an emo.
I absolutely support young people if they want to explore those identities, even around gender presentation. Even if you want to change up your clothes, cut your hair, wear makeup, don't wear makeup, wear nail polish, don't. I mean, all of those things I think are absolutely amazing and young people should be doing. It's when we start talking about um, this need to physically change the body as a teen or as a young person that really, to me, becomes that line where we're no longer supporting a young person's exploration. We are supporting a young person's self-harm.
Yeah, I totally agree, because I think leaning into feminine and leaning into masculine, I think that's really interesting how fluid that can be. I'm fascinated by it. And I've seen my friends, like my female friends on occasions, act really masculine 1 minute and then they switch into acting for feminine and they've got control over it. And it's really beautiful. I think that kind of fluidity and leaning into masculine and feminine is gorgeous and something to be celebrated, because you can switch in, you can switch back, and it's, you're just floating with whatever works. And obviously for some people it might be more static than others. For other people it might be more fluid, but you're not mutilating the body. And
Absolutely.
that's my huge issue.
Yeah.
So let's talk a little bit more about the mutilation of the body and like what happens to someone where they're fully transitioned. What do they suffer from that is not being spoken enough about?
These medical interventions create lifelong patients. And these are not easy treatments. There are so many medical risks that go along with them. We were seeing young people who already had concerns around disordered eating, whose weight was absolutely skyrocketing with the use of testosterone. We saw patients whose cholesterol, who were developing diabetes, who were needing CPAP machines for sleep apnea as a young person. These are not easy treatments, and they will cause long-term challenges if they are continued. And for all of the trans adults in my life that I care about, one of the things that's really important to them is that they had full informed consent. What they were trading, what they were recognizing that in order for them to medically transition as adults, they had to understand what those lifetime impacts were going to be. And those are things that I just do not believe children have the ability to consent to. And children also, especially teens, always believe that the bad things are not going to happen to them.
That's a really good point. What about menopause symptoms? Have you seen?
So with the puberty blockers, absolutely. We saw patients complaining of more depression symptoms, a few patients who were crying all the time, exercise, weight. They were just tired. They felt drained. They had these impacts on the body. We saw concerns around bone density. We were talking to a lot of patients about vitamin D because we saw some concerns around bone density for the puberty blockers. And then we just really saw overall health. I was always concerned that a number of these patients were not in good health to begin with. And so for a number of the girls, we did see that they were obese going in, that they already had binge eating issues, that they already had disordered eating issues. And for some of the boys, they also had disordered eating concerns, but were more on the anorexic side, had more concerns around poor eating habits on that side. So we saw a lot of concerns on both sides.
Do you think anyone could transition and not have health problems?
I think you're going to trade off something.
There's going to be something.
There's going to be a trade-off.
Mm.
But also our culture has decided that I think we used to think that that health looked like taking the least amount of drugs. I think that should still be something that we are striving for.
What happened to you, Jamie, when you started to blow the whistle?
I think two very different paths opened. I did lose a number of friends, a number of individuals I have not spoken to since. There were a number of individuals in our lives who had medically transitioned their own teens who I've not heard from since. But I also have been embraced by a huge community, amazingly, of lesbian, gay, bisexual, and trans adults who also want to see young people supported with their mental health supported, but given the time and the ability to grow up before making the decision if they are going to medically transition. And the people that I've been surrounded by now are just amazing individuals.
That's a really good point. I was speaking to my colleague the other day. So he's a gay male therapist. And he said that if he was growing up in this day and age, he would feel forced into not being
Yep.
gay. And essentially, he would be picking up on the message of, I need to be a girl now. When he was just a feminine boy,
Mhm.
he was able to be, he was allowed to be a feminine boy. And he's always been allowed, he's always felt he's been allowed to be a feminine boy. And he's now gay and has never had any pressure to even think about changing his gender.
Yeah, we hear that all the time. I think it's a common occurrence for young people who are gay and lesbian when they're growing up to experience gender issues. And I've heard from so many that if they were growing up today, they would have had their physical body changed.
Did it impact your mental health when you started speaking out and you were getting hatred or you were getting hate in your direction as a result of it? How tough was that for you?
I feel like I'm in a better place than I was. The amount of ethical workplace stress was really high. To work every single day feeling like you are complicit in an ethical medical scandal is a lot more challenging than to be outside of that and feel supported, but also I just feel like I'm in the right place doing the right thing, and
Yeah.
that's a good feeling.
What was it like for you every day to intuitively know this is really, there's something going wrong here, and have to experience the emotions of knowing that harm was being done? How did you cope, and what was that like for you?
I am immensely grateful that I was not alone, so that I had a few other coworkers who I could talk to that felt similarly.
Yeah.
And I feel like I stayed as long as I could because I was trying to at least have that voice within the team to say in case counseling, to when we're discussing a case, to be a voice. But it was immensely challenging, and what was also so difficult is that all of the individuals I work with I cared for as people. I did not feel like they were evil, mean, terrible people. I felt like on some level we were all just caught up in this horrible construct that there was on some level no way out. I said to one of our physicians once, I said, "We are harming patients." And their response was, "I know, but what do you want me to do about it?"
Wow. So actually some people
But
knew.
yes, but because they couldn't see a way to say no to some
Mm,
and reduce like there was just you just had to keep pushing forward. It was like the wheel had to keep spinning, and they were like, "Yes, we're harming some people in this wheel." The only way they could see was that the whole thing just had to stop. And that's a huge undertaking to look at it in that way and then feel like, okay, well, I'm going to become the whistleblower to just throw myself in the middle of these spinning cogs of wheels, and let's
yeah.
just see if we can get it to grind to a halt.
How much do you think financially driven motivations in relation to keeping that clinic running and keeping the conveyor belt of people coming through?
I don't think that the money was the driver. I think it was the ideological belief and the inability to figure out a way out.
To your knowledge, have any changes taken place in that clinic?
Oh, the clinic has been completely shut down.
Ah, it's been shut. When was it shut down?
So there was a state law that passed to stop any new children from going on puberty blockers or cross sex hormones. But the law allowed patients who are already on them to continue.
Mm,
And the clinic decided to close because one of the things the law changed for those who were already on and continued is the statute of limitations to sue for harm. So in the United States, in each state, it can be different. If you are medically harmed, in some states, it's as small of a window as a single year
yeah.
if you're going to sue. They opened it up to 15 years, or I believe up till maybe 21, or the age 21 years past. So they opened up the window and really broadened it that you could sue for medical harm. And for some reason, the clinic determined that their risk was too high to continue with that.
Yeah, actually,
And
that makes
so
sense.
they shut down.
Shut down, take your profit, run, and get
Yep.
out of it.
Yep.
Jamie, I lead a team of psychiatrists and psychotherapists, and we truly want to be doing the best for these individuals. What advice would you give me and that I can pass on to my team to be able to psychologically support individuals who have gender issues without kind of leading them to something that could be very harmful to them?
Well, I'll say this. It sounds like you're already running an amazing team, and I feel like you've already brought up so many of those great points. But I really think mental health care first, therapy first, centering the family, centering the child within the family unit, and looking at the overall functioning of the whole family are huge. And then centering the child too in a holistic view of health and identity formation as an adolescent. Yes, explore, think about your identity, but in the same time, thinking about that in a holistic, healthy way is the best way to ground young people into that experience of growing up into adulthood.
I think that's really good advice. Where can people follow you if they want to find out more?
Well, X or Twitter here. So I'm on Twitter at Jamie Whistle. And then I'm working with a group of LGBT individuals. We call ourselves the LGBT Courage Coalition, and we have a Substack that we publish on also. So you can find me in both of those places.
Amazing. Is there anything final that you want to mention that we haven't had time to cover yet today?
I think this is an issue that actually could bridge a lot of relationships and divide between Britain and the United States. I find so many overlaps between the care model, the Tavistock, some of the whistleblowers in England. And in some ways, I believe that you all are leading the way. And so I want to keep looking to your strong system as a point of guidance for all of us.
Do you still see a huge difference between the States and the UK in relation to this issue?
Huge difference, but we are looking to you.
It's really good to hear, but also, yeah, concerning that we have more consistency. Jamie, thank you so much. It's been so great speaking to you. And I really admire your bravery of just standing up for something where you knew there was something going seriously wrong. It must have taken a lot of courage, but it's making a difference.
Thank you so much for having me today. It's been a great conversation.
Thank you so much, Jamie. Enjoy the rest of your day.
You too.
That
Bye.
was great. Bye.